we're done here. We can all go home now. No, thank you very much for the lovely introduction, Quiche. I am going to do exactly that, and I'm really glad you set the stage like that because it helps everybody follow along. So I'm going to talk about exactly what he said, how we might be able to predict early evidence of bone metastasis in men with prostate cancer. But before we get there, we have to understand why and how and that sort of thing. And so I'm going to talk about some issues around just cancer to make sure the stage is set, some issues around prostate cancer, issues around equity amongst in healthcare, in Canada in particular, and specifically with regard to how we try to diagnose prostate cancer, manage prostate cancer, and then manage metastasis of prostate cancer. And along the way, I'll tell you a little bit about the kind of basic research our program does, and hopefully you guys will get a general sense of what it is we do. I recognize it's really technical, and I have a hard time grasping it. And I've sat in rooms with Quiche listening to us, and it's clear that Quiche has a hard time grasping it too, because these kids of ours are really phenomenal. And what they're doing is cutting edge. And so they get the credit. I'm the skipper. They are the ones who have manned the oars. So I'll talk about that work. And at the end of it, what I really want to do is basically have a conversation with you folks. That's what I'm here for. And so this is really a backdrop to hopefully educate, inspire some thought, and then let's have a conversation. And so my talk is titled Bone Metastasis, Metastatic Prostate Cancer, Translating Discovery to Detection. I know that's not all that fancy. If Naomi was here, she'd have come up with something funny. No, they can't, but my slides are white. It'll look better in a minute. Okay, and so I have to start with a couple of declarations. The first is, I don't really have any conflict of interest. So I am a board member of the Prostate Cancer Foundation Canada, as you heard. I've been there, I think I'm the longest standing board member there now. I hold funding from the Canadian Institute for Health Research, from the Terry Fox Research Institute, from Prostate Cancer Foundation down in the States, not the Canadian version of it. And we also support a lot of our trainees through a phenomenal program called BioTalent Canada. I have no financial interest to disclose, other than Murray gave me $1. Because I asked him for $1 when I got here, I got $1. There, that's my bias.
My last dollar.
Without kidding, I do want to acknowledge that the work that we're going to be talking about today was performed on the ancestral and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. I think that's how we say it. And I'm really grateful for the opportunity to come out here and present on Treaty 6 territory, the homeland of the Métis. Okay? So, who am I? I'm not in this picture. I work with this group, and I would say, I actually know when it was. It was 2019 when I had a conversation with this fellow here, Philippe Altit. And I was trying to keep him in Vancouver. He was a graduate student at the time. He was working in failed hip implants and adverse local tissue reactions that happen in people with failed metallic hip implants. And I had helped him with some of that work. And he was working for this fellow, Rizzi Wang, who is a professor in biomedical engineering and material sciences, and he's really interested in ceramics and things of that nature, and a lot of bone work. And we started talking about the ideas of how to integrate these guys' expertise in bone, because they're the experts, with my interest in prostate cancer, and how we could come up with a project that would really be different from what everybody else was doing. And so I'll start at the beginning and tell you that we focus on the patient. We focus on the tissue, the extracellular stuff. We don't focus on the cancer cells. Everybody's focused on the cancer cells. Our premise is that the cancer cell is nothing without its host. And there's an old hypothesis called the seed and soil hypothesis that states that cancer can only grow in the right soil. And we really, really adhere to that idea. Okay? None of this work would be possible without the people across the bottom here. At the University of Washington, Colm and Ava have generously provided us with specimens that they had that are now with me, some 250 specimens from men who happened to pass from prostate cancer, who donated their bodies to that program for a rapid autopsy program so that they could harvest metastatic lesions from these guys after they had died for further analysis. And we have the bone metastases, the vertebral metastases from those men. I also work really closely with Dr. Raphael Charest-Marin, who is a spine oncologist out of the University of British Columbia, and who lets us into her operating room. And so when men suffer catastrophic spinal failures due to metastatic prostate cancer, she's the one who goes in there and gives them another chance. She's the one who does surgery to do spinal fusions. And when she does that, she has to cut off some of the processes of the spine that she's trying to fuse. And so she lets us have that tissue. Well, the university lets us have tissue, but she gives us access to that tissue. And that's becoming invaluable for us. So these are real resources. And our work is human first. That's where we come from. We're looking at prostate cancer from the human. We do use cell lines and other models, but the human is where we start everything. So you guys probably all know this, but I'm going to go ahead and say it anyway. So chances of cancer in your lifetime, we know what they are. In men, 45%, in women, 44%, pretty indistinguishable. Lifetime probability of dying from cancer of some form, about 25%, 20 to 25%. That's what we know back in those days. This is a laundry list of cancers that the Canadian Cancer Society produces, and the percentage of those cancers from different sites in the body. And then on this side is mortality for those various cancers. And the real key thing here is to understand is that we have 3 leading cancers. And the other cancers matter, don't get me wrong, but we have 3 leading cancers in humans. We have breast cancer and prostate cancer, both cancers of accessory sex organs in the respective sexes. And we have colorectal cancer because everybody eats. Those are the biggies. So this is a pie chart to talk about cancer mortality in relationship to other causes of cancer. It is dated to 2021. And so there's a pretty big slice of the pie that's devoted to COVID that's shrunk tremendously. And so all that's done is increase the percentage of the other slices. So it represents a large number. And I like to show this graph to basically demonstrate that cancer doesn't have a preference. Potential years of life lost, as Canadian Cancer Society calculates, for men and women is indistinguishable. But there's something else this slide shows me. It shows me that men are morons. Okay? And I'm really delighted to see women in this audience because women count. And having somebody to advocate for you, sometimes we call it nagging, is good for us. Right? So I really appreciate that, and I hope that you spread the word and make sure that other women in the community who have men in their lives touched with prostate cancer understand that they are contributors to that. This is the good news slide, at least for prostate cancer and breast cancer. Survival from these cancers is extremely good. It's not great, but it's extremely good. And that's due to a lot of factors. Understanding of the disease, a lot of money poured into trying to figure out how to manage, diagnose, treat the disease, and some aspects of the disease that just indicate that there's indolence to it and it's part of just natural aging. Colorectal cancer is a little bit worse, mostly because we're not so good at detecting it early. And then things like lung cancer are really aggressive. Pancreatic cancers can be really aggressive. So those are different areas of the top 4 plus pancreatic as a marker for what really bad looks like and where we should be trying to head. So we work towards trying to make that prostate cancer number 0. However, we face health disparities everywhere. I'm only going to talk about Canada because that's where we are. But there are health disparities that we need to recognize. And I don't know if any of you have ever seen this sort of information, so I'm going to show it to you. So it turns out that incidence rates across Canada vary. Okay? colors are very extreme, from very blue to very light gray. And it might make you think that the numbers are really different. But in fact, they're not. It's 1.5, right? So it's not that big a difference in incidence. Incidence is generally the same. I promised them I was going to look at a number. Saskatchewan versus Alberta, fourfold. Right, you were talking about the size of cities, the major cities, Edmonton versus Saskatoon.
Yeah.
Is that about right? Fourfold?
Yeah.
Okay, just check it. And this is disparity for mortality. And here's where it kind of moves the wrong way, right? The incidence is a little different, but the mortality rates are higher in the same places where the incidence is a little higher. That's a problem. That means we're missing. There was a report a couple years ago discussing another level of disparity, the economic impact of cancer. And I don't want to put too much emphasis on dollars, because I don't really care, except for the one in my pocket, I like it. But it is important because it's an economic world, and resources are limited, and we have to best decide how to prioritize resources. There's just no way around it. And so the societal costs to cancer look like something like this. There's health system costs, there are costs for cancer caregivers, there are direct and indirect costs, so many things. And you guys can read through all these sorts of things. A couple of them really stand out to me. Data is not available. How do you put a price on the psychological cost? How do you put a price on the quality of life costs? Those are invaluable. So those I don't think should even be in the equation. I don't know how to enumerate that. But people try to figure out how to value life, so there you go. But the financial burden is significant. This is a graph of the direct costs versus the indirect costs. The graph isn't quite right. This is about, 4% of this, something like that. And the breakdown of those indirect costs to different cancers is listed here. And you can't read it, because I can barely read it. But these are breast, colorectal, and prostate. Pretty much the same. And pretty much a lot. These are costs that come out of our pockets. We already pay taxes, and so the direct costs are already covered, but because we're paying for that. But the indirect costs are things that are further burdening the patients and the communities. So I think about it like this. We need $37 billion to cover the cost of cancer in 2024. 4% of that is indirect. The country has a GDP of about $3.5 trillion. Per capita, we think about it as about 60,000. So we're 41 million people. That's $902 per person. That's how much we pay each and every person, man, woman, and child, to cover the cost of cancer in Canada per year. Okay, that's the end of that dialogue. Understanding prostate cancer. How many people don't understand what this cartoon on the left is? Can you guys see it? Okay, so real quickly, this is a schematic of the prostate 6 times in context of the urogenital system, okay? So at the top is the urinary bladder. I'll use my pointer again. See, the pointer does work on white, doesn't it? Yeah. So the top is the urinary bladder. We all know where that is because it comes about 3 in the morning. Okay? The testes are down low. We don't show those. The testes deliver sperm up through a tube into this sac here. And that delivers it down through the prostate, that's this tissue here, where it joins the urethra so that during ejaculation, the sperm can be released from the man's body. That's what it does. The prostate is the muscle that contracts during ejaculation. So that's what the prostate is doing, in addition to adding fluid to help support the vitality of the sperm. And in this first case, we have a T1 disease. Anyone here diagnosed with T1 prostate cancer willing to raise their hand? Probably a Gleason 6, one lobe involved? No. Then we have T2, a little more involvement. Might be some pattern 4 in there. Okay? I did T1 and T2 twice, I'm sorry. T3 and T4 down here at the bottom. Where the disease is encapsulated and encapsulated further. And so these are problematic cases for prostate cancer if it gets out of the prostate. If it's totally confined to the prostate, then the urology community thinks that by and large, they can be very successful at excising the prostate or irradiating the prostate, eliminating the problem before the disease has gotten away. Okay? Whereas once the disease has gotten out of the prostate, now the likelihood that the cells have spread through the body is a certainty. And so now the therapies have to be systemic. You have to treat the whole man because you don't actually know where the cells are because they hide. And that's what we're going to talk about. So how does prostate cancer happen? This cartoon I've been carrying around since 1998. It's often when I'm talking to the people that I teach, when I say that, none of them were born. But everybody here was with us, so it's actually a funny thing. So what is cancer? Cancer is a cell losing control of its ability to divide, to stop dividing actually, and to lose control of the fail-safes that every cell has built into it to stop it if it starts to grow aberrantly, usually by killing itself, or by informing the body that it's awry so that the body, the immune system, will take care of it. Also, it has to be able to then, while it's dividing, learn how to get away, how to migrate. A prostate cell doesn't inherently move. It is part like a brick in the surrounding acini of the prostate gland. It produces fluid, and it just sits there. And much like a breast epithelial cell that produces milk, they can only do that for so long before they burn out, and they have to die. And they have to be replaced again, and they have to die, and they have to be replaced again. And so that tissue is always turning over is the risk factor. The number of times stem cells, the progenitors, have to produce a new cell every time increases the risk that one of those cells is going to make a mistake. And so tissues that divide a lot, skin, lung epithelia, prostate epithelia, breast epithelia, grow a lot, and they're the ones that are at highest risk. Okay? So that cell, that green one, he's green. Just like the, what's that movie? Hulk? Not Hulk. That's the wrong movie. No, I guess they turn blue. There's a little yellow, my kids used to watch. There's a little yellow monster, and then he turns blue or green or something. Minions. That's what they were. Anyhow, so the green one. So it starts to grow. And it's just growing uncontrolled. That's how it starts. That's phase one. And we consider this localized cancer. And by the time a man is 80 years old, he has an 80% chance of having lesions that are like this in his prostate. That doesn't mean anything. That's just aging. And the chances that that man will die of that Gleason's 3+3 or lower disease is almost none. It's localized. We don't even know it's there. PSA might rise a little bit, but not a lot. However, those cells can really take off and start getting out of their glandular space. They've already learned how to dissolve their way out of that space they're supposed to be in and start to move around within the prostate, start to expand. That's truly malignant cancer. And we want to know about that because we want to identify it early while it's still within the whole prostate so that we can get it. Because if left unchecked, and sometimes even when we thought we had it checked, some of those cells escape into the circulation, into the lymphatic system, and they migrate through the body. They don't grow right away. They find places to hide. We call it senescence or dormancy. And the cells can lay quietly for a long time. So a man can be treated for prostate cancer. His PSA, all other markers can be essentially nothing for a long time, a decade. And then one of those dormant cells can reawaken and start to grow again. And now we have to deal with that. And so you get treated for prostate cancer, but you always have to be wary that you have to look for it potentially coming back. And so that's why oncologists, urologists will always want to make sure that they monitor you at some level for a long time, unless symptoms emerge. The places that it metastasizes to, first the lymphatic system. That's not really metastasis, although we do call it that, oligometastatic disease. But it likes to home predominantly to the bone. Why does it like to go to the bone? We have ideas, but there's no proof in any one direction. We'd like to try to overcome that. We also know that prostate cancer collects a reproducible set of mutations. All cancers are genetic diseases. There are problems with the genes of that cell that occurred as things were going wrong and it forgot how to control its own growth. And so there are a lot of systems that end up being reproducibly activated. We've known this now for over a decade. And the pathways that we have seen for no good reason are called PI3 kinase, AR pathway, which is androgen receptor, which is testosterone, which is a good reason, and some DNA repair pathways. And so these are the three that the community recognized early on as being the most important. So I want to spend a minute or 5 talking about therapies because you guys will hear and see them. And in the modern world, therapies have become really, really complicated. So in the modern world, prostate cancer goes through a series of clinical states, any of which, anywhere along this line, is an off-ramp to fine and nothing comes back, okay? I want you to appreciate that I showed you that 10-year survival is like 88% in Canada. So there's lots of places where this just becomes, and everything is fine. But if things don't get better, this is the progression we see of the disease. And this is a worst-case scenario for the trajectory of treatment of that disease. And so it goes through these waves, and the waves are because there are lots of therapies. Primary therapies, radiation therapy, or surgery. If PSA starts to rise again, salvage radiation therapy, or if they think that there's excapsulated disease, because it could be salvage radiation therapy. There can be other hormonal therapies, plus or minus chemotherapies. There can be more salvage radiation. Second-line androgen receptor pathway inhibitors. Immunotherapies are coming along really slowly. DNA repair pathways, and PI3 kinase inhibitor pathways. So specific targeting of known things that have happened. We learned that the cancer cells make this mistake. We develop agents that target that specific mistake. Really remarkable when you think about it. More chemotherapies, more pathway inhibitors, more salvage, really harsh chemos like platins and other radiopharmaceuticals, and that's the extent what we have. And so it works pretty well. There are something like 50 current therapies approved for treating men with prostate cancer. 50. So it's gotten to the point where, in consultation with the oncologist and urologists, therapies are tailored to the patient as best as we can. And we're trying to get better at that every day. And we have lots of tools in the arsenal. You can't use them all. You have to choose which ones to use and in what order. And so a lot of the research that goes on in the clinical space is related to just that question. What agent to use first? What agent to use second? What is the logic behind those sorts of things? How do you sequence treatments? Do you combine them? Do you spread them out? How do you deal with this? We know that there are some really interesting things on the horizon that I'm not going to talk about today that are going to be game changers in the disease. Ask. I will answer your question.
No, I was just asking what he was on.
Oh, okay. Is it on there?
I think it was on enzalutamide.
Enzalutamide. Absolutely. Lots of us are on enzalutamide. Not me, but lots of people are. I don't want to get into the details of what those drugs do right now, but if we want to understand what these drugs do, I'm happy to discuss that. Okay? The goal is to migrate these therapies earlier into the disease course effectively, to better control disease and hopefully to cure disease. So I'm here to talk about bone metastasis, and we consider it a major clinical imperative. We know that in some reports, 95%, at least 10 years, that's US kind of numbers. In Canada, we're a little more conservative about it. We call it 88%. That could be differences in healthcare system and accessibility and those sorts of things. But who we diagnose, in the States, they're more likely to diagnose and treat somebody who might have a really indolent disease versus in Canada where the healthcare system is single payer. If there's a guy who has essentially no risk of having clinically relevant prostate cancer, leave him alone. Whereas in the States, they might get surgery and some sweet dollars for surgery. So when you're motivated by money, things are a little different. I'm from the States, in case anyone wants to know. So it does happen that most men do well, but some of them don't. And over 70% of the men that do progress will develop bone metastasis. And these have historically been considered osteosclerotic, which means that they form more cancer. This is actually a relatively unique feature of prostate cancer. There are other cancers that occasionally will show increases in bone density at specific lesions, but prostate cancer does it all the time. We think that that's a fascinating problem, and we're trying to understand it. They come up as mixed typically because the disease has to progress. They're at higher risk of fracture, spinal cord compression. So this is an X-ray of a man who is suffering spinal cord compression. Can you see where that green arrow is? That's his spinal cord being pressed by the cancer that came out of this vertebrae. And you can clearly see that that vertebrae is not normal. It's collapsing. He's undergoing spinal compression. And so my colleague Raphael goes in there and takes care of that problem for this guy. She'll cut away that extra cancer. She'll open up the area so that it can be irradiated, and she'll plate it so that that spine is fixed, so that that back is supported again. They cause a lot of pain. They're really difficult to manage. So in the field for quite some time, we've had a model that comes out of that idea that I initiated with this seed and soil hypothesis. Prostate cancer goes to the bone. That's its soil. That's the place its happy place. It can live there. It can survive there. It's funny because it's almost like a wolf in sheep's clothing, because that's where the immune system is. And that cancer can go there and lay dormant, surrounded by immune cells that ought to know that that cell is not correct and ought to be able to kill it, yet don't. Why not? We're trying to figure that part out too. We, the field, not me. There are too many other people that are hot on that particular topic. And therapies to overcome that problem are some of the things that are on the horizon. The cancer cell, once there, interacts with the bone. So there are predominantly 3 classes of cells in the bone that it interacts with, we think, not the immune system. So one of them are called osteoclasts. These are the cells that dissolve bone. And some are called osteoblasts, and these are the cells that lay down new bone. And this is critical for all of us because bone is a living, dynamic tissue. It turns over all the time. You guys all remember early spaceflight and seeing images of astronauts come back to Earth and get transported away on a stretcher because their bone loss had been so severe just in that short time circling the planet. Gravity is important. Gravity matters. And so the bone is constantly responding to the stresses of gravity and load and turning itself over to deal with that load change, to clear out proteins that start to break and areas that start to break and repair them. It's a constant dynamic. You got that now, right, Keish? Okay.
After years of working with you.
This is a major point.
Yeah.
This is a major point. Bone is not static. We're not trees.
Yep. We talked about that at
Yeah,
dinner.
yeah. Even trees aren't static, but you get it. So a long time we've had therapies that try to deal with bone resorption, okay? Because we have problems with bone resorption as we age. Sex hormones decrease, and estrogens in particular are really important for bone health. And so women going through menopause and later in life are subject to high risk for osteoporosis because estrogen levels are dropping. And so the bone starts to degrade. We need to protect that. And so there was a real major push for that a long time ago. So we have agents that called bisphosphonates that get into the bone matrix. When the osteoclast tries to mine it, it just mined its own poison. It takes that molecule up into its cell, and that molecule is toxic to the cell. It'll kill the osteoclast. So the osteoclast activity is decreased. Okay? We also know how osteoclasts are activated. One of the major ways is through this thing we call rank ligand. Isn't that a great name? I won't even tell you where it came from. And there's a drug that's an antibody against it that blocks its ability to activate osteoclasts, to turn them on. So those two agents work really well to control osteoclast activity. But I told you prostate cancer is producing bone, not resorbing bone. So these are agents that aren't necessarily beneficial if you're trying to maintain a dynamic in the bone and not let it get away the other direction. That said, men who are undergoing androgen blockade, maximal androgen blockade, will be suffering from the same sorts of hormonal issues that women that are menopausal start to face, or postmenopausal start to face. Lowering sex hormone levels, especially estrogens, and that causes a regression of the bone density. And so in prostate cancer, it can become a problem where the men are on androgen ablation therapies, and their bones become brittle because you've targeted their sex hormones. So it's a balancing act. And we have to be careful about that for skeletal events, and those sorts of things will trigger the use of these agents, and that's to protect the skeleton full stop, not necessarily to target the disease. We now have radiotherapies that are really good at delivering toxic doses to the bone environment. So we have alpha-radin, which was on my list, Pluvicto, a modern drug that's been developed that targets something called PSMA that you may have heard of, and I'm not going to talk about today unless we talk about it afterwards, that selectively homes to prostate cancer cells and carries a radioactive payload that has a short path length and kills cells locally. Those agents are also in the bone, and so they're also toxic to the bone cells. The bone is a dynamic tissue. If you kill the cells that are controlling bone turnover, you've killed the bone. And so it's a tough thing to try to deal with. How high can you go in your dose to kill the cancer cells and still preserve bone life? It's a hard balance. I wish there was an easy answer. The cancer cells are tricky. They'll change the way they look. I talked about them acting like wolves in sheep's clothing. They undergo something that we euphemistically call osteomimicry. They act like a bone cell. They start producing things that their bone cell partners make. And so the bone thinks they're bone cells. Bastards. We also know that they're interacting with those bone cells. And in prostate cancer all the time, it's always interacting with a stroma, some other cells in the body. When it's a normal prostate developing, all the way through the most lethal disease, it's still always dependent, in part, on the cells that are around it and supporting it. And the osteoblasts represent that population of cells in the bone, and there's a communication between them. And so those cancer cells can change the behavior of those osteoblast cells to make them a cancer-associated osteoblast. They start producing factors that alter what's happening in the bone. They change their behavior in the bone, and we think that's the sweet spot. That's the magic that we'll be able to take advantage of to try to identify when cancer is in the bone environment. There are also cells that are buried in the bone we call osteocytes, and these are the craziest ones. There are more of them in bone than any other cell in bone, and they're buried in the matrix of the bone. And they communicate with the outside world and with each other through little tunnels that they build. And I have a student who I'm not going to talk about tonight who's really interested in the dynamics of those guys and what they do and how they get killed and how that impacts the outcome of men with bone metastatic lesions. I'll send Naomi sometime. So what is bone? I don't want to spend too much time here. Bone is really two different kinds of things, right? There's compact bone, the outer shell of bone we think about, like when you eat a chicken and you got chicken leg, and there's this cylinder of bone. That's cortical bone or compact bone. And then where the blood cells are made is a spongy bone, a lattice of bone within that space that is the support structure, just like the lattice of a bridge, that allows it to flex, respond to pressures, grow more, and support the skeleton at the minimum weight penalty. So now I'm going to pass around some things. So these are some phantoms that we've made, and I'll show you pictures of the micro CTs that they were generated from in a bit. And I just want you to pass them around the room. Okay? Each of these represents a different stage of this reticular network in bone. This one is an osteopenic or osteoporotic kind of bone. See how thin it is? I broke it. Oh no, you have to touch it. You have to touch it. This is not bone. This is plastic. These are phantoms. Okay, these are made of plastic. They're 3D printed. Last summer, we had a summer student in. The university had some 3D printers they wanted used. They said, write a grant to use our 3D printers. We did. And so the students built these. All right, you guys don't want to see them anymore? You sure you don't want to see it? You sure you want to see it? Yeah, I'll show you one of these. Here's the other side. Here's the other extent of it. Yeah. All right, just pass them around the room. Just take a look at them. Pass them around the room. We keep passing them around. Yeah. Heads up. Oh, I'm going to give him this one. Just pass them around. So this is our representation of trabecular bone. And not to put too fine a point in it, but what you're holding initially was less than 1 centimeter in diameter. Okay? And so these kids had to figure out how to blow that up without getting all grainy. You guys have all taken a shitty photograph and tried to make it bigger, and all you see are pixels. All you see are dots. Right? So we do have the same problem in a 3D printer. They had to come up with the math to smooth out those curves. Oh, I thought he was going to throw it. Anyway, so we're looking at this middle part that I'm handing you. Right? It's going to look like this. Here it is. We're looking at this part. Okay, that's what I'm passing around. And what you see are cores that were taken from the side, and that's why they look like they are. The structure is up and down. So if you look at these things, you'll see that there's a long axis and a short axis. And the long axis is the up and down. That's the supportive structure. This is a vertebrae. And so after I talked to you guys last time, we published this paper. So I was here in 2023, right? And so in 2024, we published this paper talking about these lesions. And in the literature, they were talking about, prostate cancer, sclerotic bone, that's just woven bone. And woven bone is a specific type of bone that occurs during development when new bone is being produced. It occurs during healing. If you break a bone, woven bone gets laid down first and then remodels into normal bone, right? And so that's what woven bone really is. And when we looked at what we had in prostate cancer lesions, we said, well, it's close, but it's not the same. There are features, molecular features, and structural features, and behavioral features that distinguish it from what is classically defined as woven bone. So we called it woven bone with a twist. And so this paper was working from metastases in the spine of men, using a variety of imaging technologies to determine the degree of bone loss, new bone formation, where it formed, what kind of bone was being laid down, what happened to the residual trabecular material that was in these lesions. And we were able to use confocal microscopy, polarization microscopy, electron microscopy. We even went as far as going all the way to France and their synchrotron to do some high-dimensional, three-dimensional imaging that we've yet to publish on yet. And so this is what I'm passing around now. So you should be able to look at what you've got and tell me, does it A, B, C, D, or E? Don't worry, there's not a test. Some of them are easy.
No, you always say C.
Always say B?
No, C.
Oh, C.
That's what I changed mine.
No, I think in the ones I'm passing around, the easiest one to find is D and E.
Yeah.
I think I don't have any E's. I sent around D. Right? And so when we look at, in this case, 78 of the specimens that we got from the University of Washington, and we distribute them for how much bone density they have. So we have something called a DEXA scan for what your body's bone density is. And so this is the same sort of thing for just this one area we're looking at. How dense are they? And you can see that normal is probably right around here, about, just under the 0.2 level, okay? The lytic ones are just a little below normal. These are basically normal in here. The majority of them are above normal. Some of them profoundly above normal, as you can see passing them around. So we developed this idea that we could come up with a way to understand progression by understanding these changes that we called with a twist at the protein level of these specimens. And we could maybe use that to come up with a detection system to find bone metastasis before the cancer cells really started to grow and really started to produce a lot of this aberrant bone. How early could we do it? And we have a whole hypothesis and consequences and blah, blah, blah. And at the end, what I'm going to talk to you about really is just this last bit. The work that we're doing to try to develop this blood test to help identify these things. Okay? The reason we're doing this is because bone metastasis is a problem in Canada because we detect it using really sophisticated imaging modalities. In fact, more and more, really sophisticated imaging modalities are the primary way we diagnose and monitor prostate cancer. These things require electricity, high infrastructure costs, radioactive sources, so synchrotrons, all kinds of issues that are problematic across the country. So they create an inequity across Canada. And these things predominantly impact underrepresented individuals. In the indigenous populations, severely. Racial disparities exist. Socioeconomic disparities exist. This is not true for just prostate cancer. This is true for life. But we'd like to make a difference in this, try to even the playing field a bit. And in order to do that, we need to come up with some way to risk stratify, to know who to screen, when to screen, how to screen, to best utilize precious resources for the guys that really need it. And we think our test can help do that. We'd call it a diagnostic or a complementary diagnostic, a companion diagnostic. So this is a little out of date because that's all that's been published, but this is, for example, positron emission tomography or PET scanners in Canada. And I'll let you know that Canada ranks at the bottom of the developed world for the number of PET scanners per capita, full stop. We're really under-equipped to do this in a world where that's becoming the standard by which we identify these things. And so you still just have one?
I think we have two.
Okay, two. Where's the other one?
I think there's one in Regina now.
Oh, okay.
Yeah, we have one.
So somehow I've got to get this updated. But okay, two.
We have two now.
Fantastic.
There's probably one in a vet lab somewhere. Veterinary clinic.
A PET scanner in a veterinary clinic? No, they are.
I know they are.
But we call it a SPECT. It's a different machine.
Okay.
It works. We use those. Yeah, they're different machines. They can't be used for humans. But yeah.
But Mike, the inequity for us, and you bring up a really good point, is our PET scans are in Regina and Saskatoon, and yet we've got a whole northern community they have to travel.
Right. This is
kilometers just
yeah.
to get down. So
Yeah.
That's a very good point.
This whole slide, right? That's what it's about. These things are focal. They have to be at high-density centers, well-funded hospitals, close to the resources that they need to do it. Resources include the humans that do the work. The technicians are really important. They're highly skilled people that cost money and have to live in expensive places. And they're not a dime a dozen. And because they can get paid more going somewhere else, we have a hard time retaining them. Right? So there are a lot of issues that we face to do this. So I have that here, workforce shortages, right? Provincial funding, infrastructure supplies, urban concentrations. And it results in longer diagnostic delays, the travel burden, these indirect costs, inequity outcomes because of all those sorts of issues, missed opportunities, that's the biggest burden. And then you guys know what's going on here, so I'm not going to belabor that. So how will we go about detecting prostate cancer bone metastasis early and equitably? Well, we got a plan. It's right here. I know, it's a mess, isn't it? I was talking to Murray. He said, do this. This is Murray's idea of what our plan is. Okay? So the premise is that we think we can detect evidence of cancer cells in the bone before you can detect them by seeing them. Because the bone acts as the princess. The bone can detect the evidence of the cancer cell when you can't see it. You can't see a lump in the mattress because there's a pea under it. No way. But she could detect it. They stacked them all the way up to the ceiling and she could still detect it. So can we come up with a way where we can harness what it is the princess is detecting in order to know that there's cancer cells in the skeleton before anyone else could detect that? If we could find that sort of test and do it cheaply and distributably in a minimally invasive way, then that's the kind of thing that we could expand internationally and help prioritize people who need to then get, let's go ahead and take a look, get them on a scanner if they're nowhere near a scanner, or start monitoring them closely and decide when to intervene because of that particular problem. So the work I'm going to talk about is by this fellow here named Dennis G. And I'd love to have Dennis here talking to you tonight. But he's somewhere in Italy, so I don't know. He got himself an award, he went to a big meeting, and he's taking a little time to cool his jets. So he's somewhere in Italy, but this is the work he does. And again, there won't be a test. I just have to show you the data so I can express what it is we do and give you a sense of how different things are that we can find. So what this is a two-dimensional presentation of a lot of different proteins that are present in the bone that we see from these patients. And we know what they are based on the things we're passing around, these phantoms we're passing around. Some of them are lytic, some of them are mixed, some of them are really sclerotic. And Dennis asked, what's unique about the proteins that are in these pieces of bone? And he's got some fancy techniques to be able to do that with, and he can present it looks like this. And the answer is, there are differences. The null was, there are no differences. It's just bone. It's always going to look the same. You're not going to see any differences at all. And in fact, we heard that from reviewers. And so they didn't give us any money. But we did it anyway. And we come back to them and say, well, you were wrong. There are differences, a lot of differences. And this got us really going on this project. So we're trying to understand these things. And we work in a lot of different directions to try to understand what each of these proteins actually does. And I'm not going to get into that. Okay? The other thing Dennis can do, because he loves to play with his machine learning algorithms, is he can start to play clustering games with these things. And so he can take polynomials. He can take combinations of these proteins in different dimensions. And he can look at them and say, how do these different combinations, signatures if you will, define different subcategories? And can I come up with combinations that specifically identify the lytic ones versus the sclerotic ones versus normal? And that's what he's showing here. So I'm not showing it. This is Dennis talking. So what Dennis has is 3 clusters that are statistically validated. And so at the top, he has cluster 1 that are mostly benign tissue, these gray outlined ones, or some controls. So we get controls, age-matched controls from men who have donated their body to science after they die, who died of something other than cancer. And then we can get to that same vertebrae, and we can get some of that, and we can compare it to what we have. That's our normal. That's the closest we have to normal. So that's what we have up here in the green boxes, in the green circle. Then we have cluster 2, which is this intermediate group that are predominated by cancers with relatively low bone volume over total volume, okay, low density, but mixed. If you look at them specifically, they're very, very different, and have evidence of cancer in them, the red outlines. So we know there was cancer there. Now these guys were treated heavily. So some of these guys had cancer there. They got the spot irradiated. The irradiation worked. It killed the cancer in that lesion. The cancer was everywhere else. He ended up succumbing to the disease, but that lesion was dead. And so we don't see any evidence of cancer there. But we think there was. And the signatures that we see there say there was, because a lot of the markers that give him this separation are suggestive of cancer cells being present or having been present. They left their mark. That's the important part for us. And then he has another cluster over here he calls cluster 3, which are really representative of these extremely sclerotic samples. And when I first saw these, I euphemistically called them marshmallow. And everybody laughed, yeah, marshmallow, they're soft. And then one of the students took it into the biomedical engineering lab and said, let's see how hard it is. They're really hard. But that's the problem. The skeleton needs to be able to flex a little bit. It needs to be able to give. It needs to be a bridge or a building. It has to be able to go with the flow and not fail. This is really rigid, crystalline stuff, and it cracks. And it cracks badly. So that's part of the problem we think is happening in these lesions. So anyhow, he's got these 3 groups, and these guys have really high bone volume over total volumes. I had them working from either end. We can express this kind of data a lot of different ways. It's not too important other than for you to recognize that there are patterns that appear when he plots them versus these things, and that this is unsupervised. He's got a list of markers that he thinks are important for identifying the sclerotic prostate cancer bone lesions, okay? And he applies that to databases that exist in the world for metastatic prostate cancer. And so there are 3 really big ones in the world that represent hundreds and hundreds of men who have had molecular testing for their metastatic disease. They've had metastatic disease taken, a little needle biopsy taken, and they've been characterized molecularly, and that information has been deposited. So you've heard of the Genome Project, genome sequencing. We do that. We sequence everything. And so those things are all annotated and available for researchers to investigate. And so he took that and he said, how do they identify? If you just take those things and put them on a graph and say, do they distribute relative to where the metastasis was, bone, adrenal, lung, liver, wherever, do they uniformly find places, or are they all mixed together? And the answer was they're all mixed together. He then said, what happens if I take my classifier and apply it to that data? Can I identify the bone metastatic lesions in that mess of collected things? And it's like a magnet pulling needles out of a haystack. It does a really good job. It pulls them right out. And so going from absolutely no idea of where they are, his signature improves that receiver operator curve. It improves his ability to say those things came from bone to really high confidence levels. 93 doesn't really count because that was actually the samples he originally started with. That was our sanity check. So about 80% in samples that we've never touched, in data we've never seen before, his classifier 80% of the time identifies the bone lesion. 80%. That's pretty good. However, these are guys with bona fide bone lesions, so it's pretty late in the game. So we're not very helpful at that point. The question becomes, how do we get better at it? How do we detect this earlier? And that's where this experiment comes in. And so this experiment is the thing that we really have hung our hat on for this test. What we did was we got Genome Quebec to buy in. We got a company called Illumina to buy in and provide us some in-kind support. We bought some samples, again, that we had never seen before, blood samples from an archive in the States that were drawn from men who either had bone metastasis or didn't, who had been identified as having the same kind of cancer at the beginning. They were all Gleason 8 or above. You guys know what that means? Everybody's heard these scores before, right? Gleason 8, aggressive cancer, 8, 9, 10s. So they all had a really aggressive cancer, even the guys that didn't develop bone mets, yet we had blood from them at some point there in their diagnosis. That time from diagnosis to the time the blood was drawn, about the same length of time. And so we found 8 in this database. We bought them. And so what we have are 3 samples that are metastasis-free. There's no lymph node involvement, no bone involvement, as far as their annotations, clinical annotations are concerned. Then we had 3 that were de novo bone metastatic, which means these were men that were diagnosed with prostate cancer and had bone metastasis when diagnosed. Happens more often than we want to think about. Happened to a friend of mine 2 weeks ago. All right, so bone metastasis can be detected at diagnosis. It's a bit problematic, but it does happen. We wanted that because we didn't want them having received therapies. We wanted everybody to be therapy naive. And then we had 2 guys that presented with lymph node metastases, but no evidence of bone metastasis. And then we ran some tests. And this is all kinds of fancy stuff that proves to you, or proves to me, gives me confidence that our test works. Everything is normal. Our samples are as good as any samples that Illumina can throw at them, just as controls. And when we look at these samples, we can say, well, what happens? Using our classifier, our Dennis's classifier. And what we found was that when we read out what was happening, this is the classifier Dennis uses this time, the 3 bone specimens pulled away from the other specimens in this dimension. Okay? So in this PC1 dimension, the markers that he's using there, they separate really good, which means that he can use PC1 to say bone metastasis versus non-bone metastasis. But there could be a lot of reasons for that. So now we have PC2, which is another dynamic range of what's going on in those samples that we saw. And in that case, what we see is that, in fact, the bone samples are very, very different from each other and overlap with these, which means that this is sort of our control. The cancers themselves, or the blood from these men themselves, are very, very different. But despite those differences, we still know they had bone metastasis. We only needed to know this to know that they had bone metastasis. So this pulls them out really well. And that representation is here in this volcano plot.
So Mike,
Yeah.
question,
Yeah.
and I might have missed it from one of Dennis's presentations.
Uh-huh.
What's the time difference from when they were diagnosed initially with prostate cancer to the time that you're seeing this signature
0. This is a blood draw diagnosis.
at diagnosis?
Yeah. Or soon thereafter.
Okay. So like you could envision that a man would go in, have a PSA, have diagnosis, and at the same time
Have this blood test done.
have this blood test at the same
Right,
time.
right. And so these are guys that had overt cancer, right? That by radiologic measures had metastatic disease, right? This friend of mine that I talked to Murray about earlier today was diagnosed de novo 2 weeks ago. He presented with a lump by a DRE. His urologist was concerned. He sent him for imaging, and he had a lesion that the MRI saw. He had it biopsied because we still do that. The biopsy came back, that quadrant's a 9.
So for our colleagues in the room tonight, if you get that at diagnosis, that sets up a potential plan of strategy of treatment.
Yeah, a much more aggressive therapeutic course. Right.
That would inform the urologist to say, we may want to follow this algorithm.
Yep.
plan, as opposed to if someone came back with a test where you did
We're
not.
completely negative, exactly, right. But my buddy came back with a PET positive scan, with a PSMA PET positive scan, right? FDG PET did not pick him up. Conventional PET didn't find him. A specific expensive PET that just got approved last year found it. So the conventional way we would have seen it 2 years ago, tried to see it 2 years ago, that screen was negative. With this new test, this PSMA targeted test, he had a lesion in one vertebrae that was 8 millimeters diameter. That's actually pretty big, right? So it's a bit of a problem for him, right? But again, he's identified, and now he can be treated. And this separation is predicated on the lovely heat map on the right, and I'm not going to tell you about it. So our plan is to do this. Increase our numbers. Get up to 40 and 40. Based on the data I just showed you and statistical tests, we can determine how many we have to test in order to have a 90% confidence that we're right. We can never know absolutely, but we wanted to know how many we were right. Our data is pretty good, and it says you need about 40. And so we're going to get 40 of each. 40 from guys that have prostate cancer and 40 from guys that don't. Not from anybody we've ever seen before, from a different cohort of samples that have been collected somewhere else. In this case, in Quebec. Okay? And we'll test them, and we'll look for the various biomarkers. we'll rebuild Dennis's algorithm, see how good his original algorithm was. We'll distinguish them. Then we'll go against a validation cohort of another 80 from another cohort and say, does it find it there too or not? That cohort comes from Toronto. And you know, people from Quebec and people from Toronto, they're not trading. So these are very, very different sample sets. We're pretty excited about using this approach. And having the buy-in from the Toronto group and the Quebec group to do this work is great. And all I can do is sit here and hope that my email goes ping and some reviewer in Ottawa agreed. Okay? If this works out, if this middle part works out, then we go to yet another cohort where men have been monitored. They were diagnosed with cancer. They started to get treated. They get blood drawn at different times. We know what they started with. We know how long between bleeds. We know which guys become metastatic, which guys don't. And we can go out all the way out to the end, to the metastatic state. Can we tell the difference there? Yes or no? If we can, go back a bleed. Can we tell the difference there? Yes or no? Go back a step. Can we tell the difference there? Yes or no? How early in that progression can we find it? And that's best represented by this little figure here. So we know we're pretty good out here. Well, we think we're pretty good out here, that we can tell the difference with a high confidence. He called it biomarker level. I'd call it a confidence interval. Okay? We want to know how early in the disease state can we get? And can we not just be as good as imaging, can we be better than imaging? Can we build a test that will have real value for the men in rural Canada, in urban Canada, in industrialized and non-industrialized world to really help that happen? So my conclusions are prostate cancer bone lesions cause a spectrum of pathologic bone conditions ranging from lytic to profoundly sclerotic, and I pass them around, and I'm sure that as you saw them, you knew what you were looking at. Okay? They have many, you could tell the extremes. The three in the middle are probably pretty close, but the two extremes are really easy. Okay? They have mixed characteristics, but we document differences in the presence of the trabecular bone that represent differences in osteoclastic activation. The proteomic profiles, these proteins we're looking at, reveal distinct differences between these different states of the disease. And we think these are potential biomarkers that can provide mechanistic insight. That's what we really want to understand is, why is all that happening? Do these things teach us anything about how to treat those? Because identifying it early, that's great. But now, what do you do about it? Well, we can irradiate and do those sorts of chemotherapies and things. But is there a magic trick here? Is the bone teaching us about what's going wrong that would allow us to use some drug that exists or develop a new drug that will go after that specific problem?
Mike, have you thought about a follow-up test after treatment? Like go back and do a retest?
So I guess we will actually have that at some point. We don't have blood draws at that point, but we would do that in a prospective way, right? So if all these other studies are retrospective,
Yeah.
if we can get past this hurdle, right, then with Miles and company, we would set up a long-term prospective project where we would monitor, get men to come in, we'd start applying this test, and we'd follow them through their trajectory of prostate cancer, which means 10, 15, 20 years, right? Maybe not 20, but 10 or 15 years.
Because as you eloquently said, this is a living dynamic process.
Yes.
And even though you have a static test that tells you this moment in time where you are, and even if the therapies are effective, all you need is one cell.
Right. And even to that point,
Yeah.
could we tell whether we were successful in the treatment based on changes to the bones, things?
Yeah, exactly.
And could you see how, because cancer always evolves, how the cancer is evolving to those treatments? Are there new angles that we want to consider even further down the road? Those things are not we. I'm too old for that.
This is what Mike and I do in lab.
This is not we, right? This is going to be these kids of ours that are going to do this as the next wave of scientists that are doing this.
Up when the two old guys were talking.
Yeah.
Particularly this.
Yeah. So I'm going to close with that and thank everybody involved. The most important people are at the bottom, the participating patients and families for whom and with whom this could not be possible. Our group is over here. I work with a lot of different groups around the world, the European Synchrotron, And I don't have listed here because they haven't part of this particular talk, groups in Switzerland, groups in Austria, groups in Australia. We work around the world. And people that are really important were Dennis in this particular case, and also Hans, who runs our proteomics core. Everybody else is essential in their own right. And so thanks for your time and your patience.